Dr. Ellis, please, for 6 minutes.
Thanks very much, Chair. I've set a timer. So thanks to all the witnesses for being here. Mr. Keon, maybe through you, Chair, I'll start with you. You talked a bit about bulk purchasing, and when we look at the potential medications that are covered here on this list, can you explain to Canadians, I mean, is it likely this is going to result in significant savings and lowering of prices that currently exist?
Thank you. We do not think it will. We do not think it should. We have negotiated a very broad agreement with the Pan-Canadian Pharmaceutical Alliance that covers public drug plans. It's the same price that private insurers pay, and it is a negotiated price with the provinces, the experts from the provinces, that is intended to provide good savings, good prices to Canadians, and a sustainable revenue base for our industry. So, no, we don't think it will provide savings.
Thank you very much for that, Mr. Keon. And to you, Mr. Frank, you know, there's this concept of universal single-payer plan here in this Pharmacare pamphlet. Could you tell us, I mean, the minister and the officials who were here previously couldn't tell us what that meant. They said, well, it's a, you know, it's a term that's been used a lot, and you know, everybody knows what it means. You know, you've been at this a while, and obviously I would suggest that maybe you could shed some light on this for the benefit of all Canadians of what that means.
If there's one point to underline today is that this bill is ambiguous, and we actually don't know what it means because it is not a defined term. But you know, the building of this bill, when you read it in its entirety, references to the Canada Health Act, references in the preamble to previous studies that have been done, single payer mentioned multiple times, universal. Those as a package have been well understood in the courts and over time in the provinces to mean, you know, a single payer, not federal, provincial, private, but a single payer. Universal means the same for everybody. And our concern is that that could be interpreted to also mean that private industry is no longer able to provide coverage. So, you know, when you read this legislation, because of that lack of clarity, because those terms aren't defined, we are concerned with the way it's drafted and thinks it needs to be amended at a very minimum to reflect, if the vision of the minister is what the government's intent is, we would be supportive of that, targeting, you know, their efforts on where the need is. But I don't think that we can be confident that that's what the legislation reflects. And so we are quite concerned, and we do believe there's some significant amendments required to reflect what we heard from the minister saying earlier today.
Thanks for that. And through you, Chair, is it fair to say then, Mr. Frank, that our understanding is there's about perhaps 1 or 1.1 million Canadians who lack sufficient coverage. So that could mean that perhaps of the 40 million Canadians, 39 million Canadians that their coverage they currently have could be in jeopardy?
Only speak to what we cover as a private industry. So there are 27 million Canadians with private drug coverage today in Canada. It's very broad coverage, much broader than even the best public system available across Canada. And they value that coverage greatly. 90% of them value their coverage to a high amount or to a great amount. So they want to protect it, and they are very strongly opposed to having that put at risk. And overwhelmingly, if you ask them what their preferred approach is, and you give them a choice, they would like government to target their efforts where the need is. So, you know, we listen to our clients every day. We provide excellent coverage for them. There's 27 million of them that are very happy with what they have, and they don't want to see that put at risk. Everyone would agree people should have access to the medications they need. And so let's target where the problem is, and let's not disrupt what's working well for so many.
Thank you very much for that. And through you, Chair, Monsieur Giroux, thank you for being here. Thank you for your analysis. You know, when we begin to look at federal government spending, we know that the spending is ballooning out of control. That does not mean that Pharmacare is not important. That being said, and we've heard, of course, now from Mr. Keon, there's not going to be any savings here. So this will continue to be an expense to the federal government, of course, to taxpayers. Perhaps we don't have that much time, but maybe you could outline that expense that is going to be a recurring expense to taxpayers with respect to Bill C-64.
Yes, in fact, we estimate the cost to be about $1.9 billion over 5 years, which, yeah,
wow.
billion. So that means about $400 million ongoing and increasing with population increase and inflation over time. So $400 million per year and increasing, roughly speaking.
And, sir, finally, through you, Chair, is it not true that this government has added more to the federal government debt than all other governments combined? I think I've heard that said. Is that true in your analysis?
I'd have to look at the precise numbers, but if it's not that, it's not that far off, due to the pandemic, of course, in good part.
Thank you, sir. My time is up, Chair. It's 5 minutes and 18 seconds. Oh, I have 6 minutes. I apologize. Look, I'm so eager to be good. Wow. So eager to be good. Thanks, Chair. So again, what we've heard is this government is adding significant amounts to the debt and the struggles with Canadians having to pay for that, of course. When we look at this again, Mr. Frank, if you could, on behalf of all Canadians, could you help understand what the difference between a private plan and a public plan is at the current time with respect to percentage of medications that might be covered by a private plan?
Typical private plan will cover almost all medications that have notice of compliance. So a typical plan would cover upwards of about 15,000 different drugs. Typical public program would cover less than half of that, and so that's sort of the delta that you tend to see. What you tend to see in the diabetic space in particular, what you will see is that private plans will cover many of the more sort of innovative, cutting-edge things. So things like weekly injections, fast-acting mealtime injections, insulin specific for diabetic comas, things that are not covered on the public plan, we do cover privately. And that's something that I think when we looked at the list that was published with this Pharmacare Act, we were concerned at how narrow it was. I think others have noted that too. So, the vast majority of Canadians have very, very robust plans, covers essentially everything in the market. And we work really hard to make sure that we're doing that in a sustainable way, and we know that they don't want to see that put at risk with any new government programs.
Thank you, Mr. Frank. Next, Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you very much, everyone, for being here. Appreciate your presentations. It's interesting that we heard one of our members repeat something that I've sort of hit on a number of times, is basically targeting efforts where the need is supposedly supposed to be. Mr. Frank, you sort of hit that right on nail on the head. You talk about the use of $1.5 billion and putting it to a situation where it may be more effective. Ultimately, when we look at stats that suggest that 1.1 million Canadians don't have any type of plan, and up to 3.8 million are not either aware of a plan that they could have or don't have the funds or choose not to do it. It's a 10% population of Canada, roughly, that doesn't have access to it. But putting that 1.5 billion to that population, I wonder if you would expand on where you think that might be of great value.
Run some simple math on this. It's going to depend on how broad a list of medications you cover, but the typical cost for someone on the ODB program here in Ontario is roughly $1,900 a year. And so if you take that 1.5 billion, if that was an annual thing, you could probably cover most of that gap and provide access on the ODB. So these are just, I think, it's an illustration of the choices that we can make, targeting federal funds where it will make the most impact. Using money to simply replicate what's already in place for 27 million people is, in our view, not the best use of scarce federal resources. And in fact, switching people off of a private plan onto a public risks them actually having weaker coverage than they do today. So I think the vision the minister outlined this morning, we are completely aligned with. I'm not aware of anybody who's suggesting the system can't be improved. I don't think anyone has argued that today. But we should be targeting our efforts where the need is, and not risking disrupting what's working for the large majority of Canadians. As you said, that's sort of 90% of Canadians today.
Thank you for that. And we've heard throughout today, and I think there's been many comments and talked about this legislation not being clear. And it doesn't define things appropriately. I mean, it puts in definitions for a minister, but doesn't put in definition for a first payer. It's very unclear in many ways. And Mr. Keon, you also talked about issues that we're not defining, in particular when we talk about the bulk purchasing. And I'm wondering if there was a way to take a look at that bulk purchasing, would there be any suggestions that you might have to add to that?
Thank you. We would remove the term. We don't like the term. I mentioned that we negotiate our prices with provincial governments. The 3 large federal plans are included in those negotiations. Our prices apply to all Canadians. Public and private reimbursed prescriptions are all at the same price for generic medicines. It is a universal plan. It is a national plan we have. It is negotiated with our industry and the experts who run the drug programs, who know what the drugs do. And it is the most recent one, just came into force in October. We would like to see that continued and respected. And we think that the term bulk purchasing is very unclear, and we're not sure what it means in the bill. So we would like to see it removed.
Thank you for that. I appreciate it. Mr. Giroux, and it's good to have you here. And I recall one of the first meetings that we had when I was chair of the government operations, and the discussions we were having about finances. And in many ways, I felt that you were apologizing for the fact that where we used to use terminologies of millions of dollars, we're now using the terminology billions of dollars. And I think Canadians need to understand that. They really don't understand that we've made that. As I said to you at the time, my wife and I used to talk about nickels and dimes. And now we're talking, instead of millions of dollars, we're talking billions of dollars with this government and the huge amounts of the costs. So when we look at the costs, and in particular, you talked about the $1.9 billion. One of the things that I'm just wondering if you can clarify, especially for someone, because I do have your report here with me, and where you talked about the public drug plans will be $14.8 billion in 2024, increasing to $17.3 billion in 27-28. And I'm just wondering, for people who hear these numbers being thrown all about, they hear numbers and they just question, okay, what are we talking about here when we hear $1.9 billion over 5 years versus
Dr. Kitchen, you're
numbers
past
like
time. If you can get to your question, we'll ask for a brief
Okay.
response.
If you just comment on that, please.
Briefly, please.
Costs that were referred to in our October 2013 report are the aggregate expenditures on public drug plans, and they are expected to increase, and that's the cost for the drugs that would be covered under a national Pharmacare program.
Thank you, Mr. Giroux. Dr. Kitchen.